you, Professor Coleman. This session is on myelodysplastic syndromes, and I have great pleasure in introducing Dr. Raymond Wang from Department of Medicine and Therapeutics at Prince of Wales Hospital, Hong Kong. This is long biodata, so I'm not really going to read it out. And Professor Wang will talk to us about molecular classification of myelodysplastic syndromes.
Thank you, Dr. Berman, for the very kind introduction. Good morning, ladies and gentlemen. First of all, I'd like to thank the organizer for giving me the opportunity to give this presentation. So in the coming 15 minutes, I'm going to discuss about the molecular classifications of myelodysplastic syndromes. So as you all know, myelodysplastic syndrome is not a single disease entity. It's actually a very heterogeneous group of hematopoietic disorders, and there's actually a wide variation of the clinical course and prognosis of patients with MDS. So therefore, it's necessary to have a good classification and also prognostic system that allow risk stratification and help us to guide the treatment of these patients. So in the last 20, 30 years, a number of different classifications have been designed and published, and this is one, the year 2008 WHO classification, which I think is most of us are using this as a classification. But however, in the last 30 years, the diagnostic evaluation and classifications have been relied mainly on peripheral blood findings, as well as the morphological evaluation and the cytogenetic karyotyping of a bone marrow sample. Even with this sort of classification system, even with the 2008 WHO system, there's still significant heterogeneity in phenotype and outcomes persist within each of these categories. So therefore, in order to increase our prognostic sort of information, there's been various prognostic scoring system has been defined. The first one is a very important one, which is still used nowadays, is the IPSS prognostic scoring system, which is actually published in year 1997. But recently, we have some more updated informations using a much bigger database and to actually evaluate this sort of various cytogenetic abnormalities on the impact of the prognosis of the patients, and that's coming up with these new cytogenetic classifications of MDS, using much more detailed stratifications of all these cytogenetic abnormalities and classify the patients into various sort of prognostic groups. And with this, so as a background, now the IPSS has been revised, and we now have this revised IPSS scoring system using this sort of new sort of cytogenetic groups, and which help us to better stratify the prognosis of the patients with various MDS. But however, even with this revised IPSS scoring system, there's still a problem, because actually about 50% of the patients do not have any cytogenetics abnormality demonstrated on conventional studies. But we know that MDS is not actually limited to cytogenetic abnormalities. There are many different kinds of recurrent somatic mutations that we can find in patients with MDS. And in recent years, with the advances in technologies and also the gene sequencing, we have a lot more information about the genetics in patients with MDS. This is a study published last year showing you the different frequency of the driver mutations identified in a relatively big group of patients, more than 700 patients. And you can see here that, in fact, in MDS, basically it's characterized by mutation in more than 40 genes. And this is very complicated because there's actually a complex structure of gene-gene interaction and extensive subclone diversifications. So basically, like Professor Tin has described this morning, the genes mutated in MDS is actually pretty close to those mutated in AML. And basically, all these mutated genes can be classified into different categories, such as the transcription factors, epigenetic modifiers, the mRNA splicing factors, signaling molecules, tumor suppressor, and also the cohesive complex proteins. As you can see here, a lot of these genes may actually be implicated in the pathophysiology of the disease. So this is a summary of all the sort of many sort of quite large-scale study actually demonstrating the reported frequency of genetic lesions in MDS. As you can see here, the mutations in the splicing factor genes and also some genes related to the epigenetic modifiers and also transcription factors have been encountered relatively commonly in patients with MDS. So how can these sort of molecular markers can actually help us in our clinical management? First of all, it may help us to actually improve our diagnosis and classification. It can actually provide some prognostic information to us. And there's now some information that they may actually provide some guidance on the treatment of patients with MDS. So let's talk about the diagnosis and classification part. Now, this is a study published 2 years ago trying to evaluate the frequent pathway mutations of the splicing machinery in myelodysplasia. So in this study, you can see that they have recruited quite a big number of patients with various types of MDS and also some patients with different type of AML, MPN as well. And you can see that, okay, even if within the categories there's been a mixture of different gene mutations being identified, but in this study they've been able to identify that the SF3B1 gene have been quite commonly mutated in patients with ring sideroblasts, while the SRSF2 gene has been quite commonly mutated in patients with CMML. So this suggested that there may be some sort of genotype and phenotype correlation, that the SF3B1 mutations may actually help the diagnosis of patients with sort of various forms of ring sideroblasts, while the SRSF2 may give you a little bit some more information for patients with CMML. In another study, this one actually tried to evaluate, focus on a group of patients with low-risk MDS with deletion 5q. And it's actually, they focus on the study of the TP53 mutation status in this group of patients. So they have about from 50 consecutive patients with this IPSS low-risk or intermediate risk patients. And in this case, they have actually studied the TP53 by next-generation sequencing. And they have also, in this study, evaluate the P53 status by using the immunohistochemistry on the sequential bone marrow samples. They've been able to find that even in this group of relatively lower risk deletion 5q syndrome, the TP53 mutation status can actually further stratify or classify this group of patients into two groups with actually different prognosis in terms of the probability of freedom from AML and also the survival as well. And they have actually correlated this with the expression of the P53 by using the immunohistochemistry method. So this is actually helping us to further sort of stratify our patient, even with a lower risk MDS, into different groups of patients with different prognosis. Now, of course, as I've described, MDS is not a single gene disease. So it's actually a very mutation with a number of genes, and also some of these mutations may coexist. So in the past few years, there are a number of very important studies sort of trying to evaluate in a very comprehensive way the impacts of multiple gene mutations on the prognosis of patients with MDS. So this one was actually published in New England Journal of Medicine 2 years ago. They actually analyzed 18 genes using different techniques on more than 400 patients with MDS. You can see this is a summary of the commonly mutated genes, the TAC2 and the ASL1, as well as the other genes, the frequency of distribution among different karyotypes of patients with MDS. And they have put it into a sort of multivariate model to try to evaluate the impact of not only this, some of these gene mutations, but also the traditional IPSS risk group, and also the age, and also etc., and other risk factors to try to see if there's any impact on prognosis. As you can see here, the mutation status of 5 genes, the PP53, ECH2, the ETV6, RUNS1, and also ASXL1, have been shown to have impact on the survival of the patient. So they actually put in the model, and you can see that how you can help us in sort of determining the prognosis of this patient. So if you look at this part, this is a group of patients who have actually got the sort of relatively low risk group of according to IPSS. If you're looking at the mutation status of the 5 genes, the presence of any mutations in any one of these genes can actually shift the patients from a really low risk group close to the intermediate one. If you talk about only intermediate group 1 patients, if you further again stratify them according to the mutation status, the presence of mutation again will sort of move them up to the next higher risk level. This is also similar in intermediate 2. So if the patient with the intermediate 2 risk, according to IPSS risk group, has actually harbored some of these mutations, their prognosis is actually more or less overlapped with the high-risk IPSS group of patients. In another study, okay, this one is trying to use the next generation next sequencing technology to try to evaluate a big number of genes, 111 genes, across more than 700 patients with MDS and closely related disorder. They have found that about 80% of the patients had one or more oncogenic mutations. So this is how when they look at the prognosis of these patients in terms of the leukemia-free survival and the incidence of AML transformation here, you can see that actually the number of gene mutations that they have identified from these driver oncogenes has actually have impact on their prognosis. So you have more gene mutations, that actually you can see the prognosis is actually worse. And if you see here that those patients who's got without any mutations, they actually got relatively good prognosis. So they summarize that and think that the total number of oncogenic mutations and early detection of any subclone mutations, which will actually signify some clonal evolutions, are significant prognostic variables in patients with MDS. And finally, this paper was just published in this month's Leukemia, and they actually tried to evaluate an even bigger group of patients, more than 940 patients with various MDS subtypes, and they screen for mutations and deletions in more than 100 genes using the sort of target deep sequencing and array-based genomic hybridizations. Again, in this study, they find that about 90% of the patients actually harbor at least one mutations. The median is about 3 per patient, and it ranges from 0 to 12. And again, quite similar to other study, they find that 47 genes were significantly mutated with TAC2, SF3B1, etc., which have mutated in more than 10% of the cases. So this is just, showing the frequency of distribution of various genes having the mutation in different type of MDS. But if you look at this one, you can probably see that for those patients who got more advanced stage disease, such as RAEB 1 or 2, the patients has actually got overall more mutations being identified, and also they have got per case, they have actually got more mutations per cases. So they actually try to put this, they try to analyze the prognostic implication of this kind of genetic mutations, and they construct, a sort of prognostic models. And this is the one actually using, as list here, 14 different genes, which has been analyzed to have prognostic implications, and they calculated the log hazard ratio as shown here. And this is one of the model. And in the other model, they also incorporate the age, the gender, as well as the revised IPSS prognostic scoring into this model. And they've actually evaluated the prognostication implications of these sort of models, in sort of stratifying the prognosis of patients with various type of MDS. As you can see on the left, this is the prognostic sort of assessment of all these patients with IPSS, using the IPSS revised system. So you can see the low, very low, as well as the high risk, different categories. So on the other hand, in this, in the middle one, they're actually using all the genetic variables of that 14 genes. This is the model 2 they use. And you can see that by using this sort of prognostic model, calculating the scores, they can actually quite well stratify the patients into different categories. On the other hand, if you combine those, with age, gender, revised IPSS, as well as the 14 genetic variables that has been shown before, they have now constructed a model which is actually performing very well, even very good, compared with even the genetics and also the IPSS alone, that they can stratify the patients into very different kind of prognostic groups. So this is the validation cohort, again, showing very similarly that the models including the genetic variables has got very good sort of prognostications in terms of these patients with MDS. So finally, there's been also some early information about the implication of all these genetic mutations on treatment. So this is one of the studies actually showing that in patients who have got treatment with high, this is the intermediate 2 and also high-risk patients receiving treatment with azacitidine, you can see that the TAC2 gene mutation status actually has implications on the outcome of the patients. Those patients who've got the TAC2 mutated gene has actually show a higher response rate compared with those who got the wild-type TAC2 genes. So in the future, if we have more and more information, it may actually help to guide us the most appropriate treatment for this group of patients. So, but however, although I've shown you that all this sort of very beautiful, model trying to stratify the patients, I think we still have a lot of challenges facing all these sort of molecular genetics in clinical settings in MDS, which has been summarized very well by Prihar in the recent ASH meeting, in the review lecture. The problem is that we have now, with the available, the advances in technology, we have now more and more cancer sequencing information, which is growing faster than our ability to interpret or validate the result. And also, this kind of somatic mutation is not that simple because they are not simply something like binary. There may be sort of subclone evolution, etc., etc. And also, all this sort of mutation in the same genes may not have the same consequences. And I've already shown you that many patients may harbor more than one mutations in one gene. So they have mutations in different genes can co-occur in the patients. And finally, the relative importance of this molecular genetics versus the clinical features, like anemia, cytopenias, we still need to have further study to evaluate that. But I think in summary, I think the technological development over the last 10, 20 years have actually enabled us to identify many more new genetic lesions. And we've now, in the recent few years, we've seen a lot of these large-scale studies published and showing us the impact of these genetic informations, not only in the disease pathogenesis, but also telling us a lot of diagnostic as well as the prognostic information. And we hope that in the near future, these sort of specific mutations will guide us not only on the diagnosis, subtype classification, and also help us to guide the clinical management, and we'll have some form of modification of our classification system as well as the prognostic system based on these molecular markers. So this is the end of my presentation. Thank you very much for your attention.